Welcome, and thank you for joining us this afternoon for Northwestern's Robert J. Havey, MD Institute for Global Health webinar, Antimicrobial-Resistant Infectious Diseases, an Expanding Global Threat. My name is Jen Burke, and I'm a member of Feinberg's Development and Alumni Relations team for the Havey Institute for Global Health. Today's event will begin with a welcome from Dr. Robert J. Havey, followed by a presentation from Drs. Claudia Hawkins and Egon Ozer, with a moderated discussion afterwards. Now, I am pleased to introduce Dr. Robert J. Havey. Dr. Robert Havey is the Deputy Director of the Havey Institute for Global Health, Director and founder of the Global Health Initiative Fund, and Clinical Professor of Medicine at the Feinberg School of Medicine. Dr. Havey is an internal medicine physician at Northwestern, where he is currently the Medical Director for Northwestern Primary and Specialty Care, a Vice President of Primary Care Operations for Northwestern Medical Group, and the Chief Medical Officer of Northwestern's new medical group in Naples, Florida. He is a tireless advocate for global health and for the importance of primary care in all health systems. Northwestern University Feinberg School of Medicine's Havey Institute for Global Health has a mission to expand knowledge and build capacity in global health through transdisciplinary research and education partnerships. Thank you, Dr. Havey.
Thanks very much, Jen, and welcome everyone. It's my pleasure to introduce our two speakers today. They are invaluable members of the Global Health Institute. The work they do is incredible, and the amount of time they selflessly give is really inspirational. They really are building capacity in low and middle income countries and helping literally millions of people. We've recognized that antimicrobial resistance is becoming a large global issue. Even here in the United States, we have patients that are dying literally every day because antibiotics are no longer working on their infections. So I'm looking forward to hearing, as I know you are too, the discussion today from Dr. Hawkins and Dr. Ozer. Dr. Claudia Hawkins is herself an associate professor of medicine at Northwestern's Feinberg School of Medicine. Her specialty is infectious diseases, with a focus on the care of individuals with HIV and with viral hepatitis B and C. She's director of the viral hepatitis HIV co-infection program, and she oversees the clinical management of patients with HIV and viral hepatitis B and C in a large outpatient clinic, teaching rotating fellows, residents, and students. She's principal and co-investigator on a number of other epidemiologic studies involving patients with HIV, viral hepatitis B and C, and liver cancer, as well as participating in a number of trials investigating novel and innovative hepatitis B agents. Most of her research is conducted in Africa, particularly in Tanzania and Nigeria, where she also provides technical and clinical guidance to large treatment programs, and she mentors junior faculty on research through global health research training programs. Finally, she is a principal investigator of an NIH Fogarty International Center funded HIV research training grant. Dr. Egon Ozer is an assistant professor. Dr. Egon Ozer is an associate professor of medicine at Northwestern University's Feinberg School of Medicine, also in the Division of Infectious Diseases. He received his PhD in molecular biology and his MD through the Medical Scientist Training Program at the University of Iowa. His research focuses on genomic exploration of microbial pathogens. What is the gene structure of these organisms that make them more dangerous for human beings? We've learned over the years that you really have to go beyond just antibiotic susceptibility. We need to understand how these microorganisms are built genetically, and we're going to hear about that today. He's devoted his career to determining the genetic patterns of these antimicrobial resistant organisms, both in bacteria, fungi, and viruses. He's the director of the Center for Pathogen Genomics and Microbial Evolution at the Havey Institute for Global Health, where he and his colleagues work to expand access to genomic surveillance of infectious diseases in partner countries around the world. Thank you for joining us today, Claudia and Egon.
Thank you so much. So I'm Claudia Hawkins. I'm going to start these slides just with a brief overview of what AMR, antimicrobial resistance is, some of the global epidemiology, and talk about some of the risk and some of the resistance patterns. And then I will hand over to my colleague, Dr. Oza, to talk about some of the ways we're combating antimicrobial resistance globally, some of the work his important center is doing as well. So I will start, and Dr. Oza, if you could just move the slide forward one. Thank you. So first of all, what is antimicrobial resistance? So antimicrobial resistance occurs when microbes such as bacteria, viruses, fungi, and parasites no longer respond to antimicrobial medicines. So i.e. they develop or acquire mechanisms to resist the treatments that once inhibited them. Resistance occurs, we'll talk about a little bit later how it occurs, but it occurs through the development of either de novo mutations or the transfer of genetic material encoding resistance, such as through gene transfer. And that resistance makes infections much harder to treat and threatens the effective prevention and treatment of an ever-increasing range of infections, leading to obviously prolonged and severe illness and, in some cases, death. Antimicrobial resistance is a widespread global problem targeting every population in the world, and thus the WHO has recently declared antimicrobial resistance, or otherwise known as AMR, as I will refer to it from now on, as one of the top 10 global public health threats facing humanity this day. Next slide, please. So worldwide, antimicrobial resistance is estimated to contribute to nearly 9% of all deaths, making it about the third leading cause of mortality globally. In 2019, a large study that was conducted called the Global Burden of Antimicrobial Infection estimated that there were approximately 13.7 million infection-related deaths worldwide, with antimicrobial resistance-related infections directly contributing to about 1.2 million deaths, and probably indirectly to another 5 million deaths. Antimicrobial resistance deaths are now surpass deaths from the most other common and widely known infectious diseases such as HIV and malaria. In the US, there are about 23,000 deaths from AMR each year, but that's probably an underestimate due to underreporting, limited surveillance in some programs, and challenges with attributing deaths directly to resistant infections. Over the next couple of decades, AMR is predicted to rise substantially. And by 2050, we estimate AMR is probably going to contribute to about another 8 million deaths annually, which obviously poses a significant threat to healthcare systems worldwide through increased morbidity from widespread infections, prolonged hospitalizations due to treatment failures, and rising healthcare costs. Next slide, please. So there are a number of populations at risk more risk for antimicrobial resistance. So it does pose a lot of threats to the young in particular, particularly those less than 5 years, those in the neonatal period, the old, over 65 years old, and those with immunocompromising conditions or certain chronic conditions like cancer, diabetes, for whom the emergence of drug resistance infections is accelerated by the use of prophylactic antibiotics, or the need for long-term treatment with antibiotics. And it's estimated about 1 in 5 deaths caused by AMR occur in children, and particularly in low-income countries, this is a problem. It's estimated that AMR increased about 80% in persons aged over 70 between 1990 to 2021, thus showing how this aging population is now at considerable risk. And the AMR burden and mortality related to AMR is also significantly higher in lower resource income settings, particularly sub-Saharan Africa and parts of Southeast Asia. And that same global burden of disease and AMR study that I referred to earlier has estimated that there will be about 11.8 million attributable AMR deaths between 2025 and 2050 in India, Pakistan, and Bangladesh, which are the Southeast Asia countries most highly affected. So there are 6 priority pathogens that that account for most of the AMR deaths, and many of them you probably have heard of. The common ones like E. coli causes urine tract infections, Staph aureus causes bloodstream infections and all sorts of skin infections, Clade pneumo, Streptococcus pneumonia causing pneumonias, and Pseudomonas. And these priority pathogens are, they're not just contribute to death, but have been shown to increase substantially over the last few decades. MRSA, deaths from MRSA have increased from 57,000 in 1990 to about 130,000 in 2021. And likewise, increases in resistant gram-negative pathogens. So the standard E. coli's are no longer standard. Next slide, please. So this is just a timeline of antimicrobial resistance, which I thought was interesting to share. I mean, antimicrobial resistance is actually not something new. Natural resistance among bacteria has been shown to exist long before antibiotics were available. And following the introduction of the first antibiotics in clinical use around in the 1940s, such as the sulfonamides and penicillin, resistance to those antibiotics developed pretty quickly. And we saw penicillin resistance in staph almost as soon as we'd started using it, and streptomycin resistance for TB, for instance, developed pretty quickly after we started using that for tuberculosis. The 1950s could be really described as the golden age of antibiotics, with the widespread introduction of tetracyclines, chloramphenicol, macrolides, aminoglycosides, and the cephalosporins like Keflex. But shortly thereafter, all of them were followed by some descriptions of resistance to all or most of those antibiotics. And in fact, the first case of methicillin-resistant Staph aureus, MRSA, which everyone will be very familiar with, was actually described as early as the 1960s. In the 80s to 90s, we'd started to recognize much more of a widespread resistance problem, noticing things like VRE, so vancomycin-resistant enterococcus, some multi-drug resistant TB, and some more resistance with some of the gram-negatives, which were all kind of developing in the context of stagnation and the discovery and development of new antibiotic classes, and sort of reliance on those older antibiotics with nothing new being developed. And it wasn't until really the 2000s that the global AMR and its drivers were recognized, and really not until 2020 when the WHO, the CDC, and the UN declared AMR as the top 10 global health threat that I referred to earlier. So next slide, please. So this slide, don't want to get too technical here, but really just describes some of the mechanisms of antimicrobial resistance for those in interest. As I mentioned before, microbes acquire resistance in 2 main ways, through de novo mutations, which show these random genetic changes in the bacterial genome that can alter gene targets or metabolic pathways and make the antibiotic less effective, or gene transfer, which is where bacteria can obtain resistance genes from other bacteria through a number of mechanisms. So once acquired, these genes and mutations enable bacteria to survive antibiotic exposure through a variety of mechanisms, which are outlined in the figure and on the left-hand side of the slide. And those include mutations that block the access or restrict the access of the antibiotic into the cell, or efflux pumps that get rid of an antibiotic, or the production of enzymes that inactivate or destroy an antibiotic in the cell, or mutations that alter antibiotics binding sites so that antibiotics no longer work. And then the next slide just outlines some of the, I just thought it would be interesting to show some of the mechanisms involved in some of the common antibiotics that we use and how they're rendered ineffective for some of the common infections that you would recognize, like Staph aureus, E. coli, with things like mutations in the penicillin binding proteins, are very common mutations that render penicillins inactive against Staph aureus, a very common infection, and likewise some of the same mechanisms going on that render some of the common or UTI organisms such as E. coli ineffective with Cipro. So next slide, please. So what are the primary drivers of antimicrobial resistance? And I think this is probably the most important slide because I think we under-recognize many of them. And the primary drivers of antimicrobial resistance really cross many sectors, including not just human health, but animal health, agriculture, and the environment. And the primary main drivers really are the misuse and overuse of antimicrobials, both in animals and humans, and animals more so actually than humans, depending on the country. But in the routine use of antibiotics in livestock, poultry, agriculture, for growth and promotion of disease prevention, really leads to that selection of resistant bacteria that can spread to humans through the food sources, water, the environment, pollution. And among humans, misuse and overuse is really due to the unnecessary prescriptions. So for things like viral infections, like common colds, flu, we see an awful lot of antibiotics being used unnecessarily. Incomplete treatment courses can lead to the selection of resistant organisms. Over-the-counter use of antibiotics and sort of self-prescription or self-prescribed medications can lead to unnecessary use of antibiotics. And we see that very commonly, not just here, but also in lower middle income countries. And within healthcare systems, we see, there's obviously limited antimicrobial stewardship programs. If they don't have good antimicrobial stewardship programs, like we're fortunate to have at Northwestern, that can lead to a lack of monitoring of antibiotics and sort of policing of it. So it leads to overuse that way. Other factors include the lack of access to clean water and sanitation and hygiene in both animals and humans, and that contributes obviously to the spread of AMR through healthcare facilities as well as agricultural facilities and ongoing transmission of resistance. And then other things include the poor access to quality, affordable medications, vaccines, and diagnostics that limits our ability to diagnose and prevent and treat infections appropriately. Thus, using the correct antibiotics for the appropriate duration, not too long, not unnecessary use of them, and diagnostics. Obviously, being able to diagnose infections quickly allows us to actually not use, so avoid unnecessary use of antibiotics as well. Other things include climatic factors, so global warming, high winds, rain, all increase the risk of spread of contamination. Globalization, human mobility, tourism, displaced persons, which are actually more of a problem than tourism, where can influence the dissemination of antimicrobial resistance. And not just today, when I was rounding, I was seeing a recent traveler to Asia where they had returned with a particularly resistant Shigella organism. And we see this almost all the time, and UTI organisms as well. There's obviously a high increase in the high-risk populations. We talked about those earlier, especially our aging population, which is burgeoning all over the world. So we will see more populations at risk of AMR. And then I think just other things to note are sort of the more on the national scales or sort of legal law regulation scales. If we don't have sort of regulation at local levels and national levels of antimicrobial policies, in wastewater management, antimicrobial pollution, we're never going to get around our antimicrobial resistance spread. So next slide, please. So with all that said, there are going to be obviously many long-term impacts of antimicrobial resistance that we face if we don't tackle AMR effectively. And these can be broadly defined into individual and healthcare systems level, at the economic level and the societal level. And sort of at the individual level and at the healthcare system level, we're obviously going to see increased morbidity and mortality from multi-drug resistant infections. Common infections, like I just said, the UTI, the diarrheal case, are going to become much more difficult to manage. The AMR burden on healthcare systems is going to really strain our resources, compromise our care, and we're going to continue to see outbreaks of MDR infection, multi-drug resistant infection. On the economic level, health sector costs are supposedly estimated at $1 trillion additional by 2050 that AMR will contribute to. We're going to probably see, even the next couple of decades, is a decreased productivity through and sort of economic growth resulting as a result of that. And economic growth declines as a result of that through declining health of the workforce, from more morbidity from these infections, as well as impacts on our food production, as well as safety. And then at the societal level, we're going to see widening health disparities and global poverty It's estimated that AMR, I think the World Bank has reported that by 2050, AMR could push more than 28 million people into extreme poverty. And this obviously will cause the potential for a lot of societal unrest, security risks, and strains on public health services. So with that, I'll just move on to hand over to Dr. Oza to discuss a bit more on the mechanisms of resistance, what he's doing in his lab and in his center, and more globally to combat AMR.
All right, thank you, Dr. Hawkins, for that wonderful overview of the history of AMR, what the basis of AMR is, what the clinical impacts of it are. But like she said, I'd like to talk a little bit more about sort of the global impact of it, as well as some of the approaches that we here at the Havey Institute for Global Health are taking to try to, as well as others around the world are trying to take to address this problem. So as I think Dr. Hawkins already kind of alluded to, that the AMR is a global problem, but it's not necessarily the same problem around the world. Certain regions of the world are a bit more impacted, or can be significantly more impacted by antimicrobial resistance. And so what I'm showing here is an outcome of a study from a few years ago where they compared rates of antimicrobial resistance in a number of different bacterial pathogens that have clinical importance, and those are identified by the different colors on these graphs, and their resistance rates to different antibiotics that are commonly used against them. And so the graph on the left is showing the antimicrobial resistance rates across several high-income countries in North America and Europe and others, compared to a sampling of antimicrobial resistance rates in low and middle income countries. And I don't think it's too hard to see that in general that resistance in multiple different organisms tends to be higher in infections from low and middle income countries. And so the burden there in places outside of the US and other high income countries can be higher in several instances. But again, because the world is interconnected, but the problem isn't necessarily the same in all different regions of the world. Even the way that bacteria become resistant, or the mechanisms whereby they develop resistance to different antibiotics, is not necessarily the same in different parts of the world. And so here I'm showing an example from a study a few years ago, looking at a particular organism, Pseudomonas aeruginosa. This is an organism that is renowned for its development of antimicrobial resistance. It can cause infections, particularly in those that are immunocompromised or in intensive care units, and has been especially a big problem for chronic infections in those with cystic fibrosis. But this is just showing different regions of the world and what the most prominent genes or mechanisms whereby these bacteria become resistant to just one type of antibiotic, these carbapenem antibiotics, of which meropenem is one of the more commonly used ones, and just showing that in different parts of the world, the problem is different, that you can't assume that the way that bacteria are resistant to a particular antibiotic in the US is going to be also the way that they're resistant to that antibiotic in different parts of the world. And that does have impacts in both how we track these infections, how we prevent them, and how we can develop treatments for them. Certain treatments that might work in one case may not work in others, depending on how they've become resistant. So some of the ways that we're taking, that we and others are taking to combat antimicrobial resistance are, in general, by first preventing the infections. If you don't get an infection in the first place, then you don't have to worry about it being resistant to antimicrobials. And so just finding ways to prevent infections from happening in hospitalized individuals or those in the community. As Dr. Hawkins alluded to, overprescription of antibiotics is a big driver of antibiotic resistance, and I'll show you soon in some of the mechanisms whereby that overprescription can lead to AMR. But by adopting programs around the world to try to reduce the use of antibiotics when they're not necessary, we can help reduce the impact and the burden of AMR. Stewardship programs, for a similar reason, those that in hospitals or at the community level that try to restrict the use of antimicrobials that are unnecessary, have had a huge impact in the US, but are less adopted in other parts of the world. And so they can help reduce AMR. Reducing antibiotic use in animals and agriculture. there's a region where there's a lot of overuse in some parts of the world, less so where there have been bans enacted within the US and other countries, but in lower and middle income countries where there are no such bans, then there still can be wide use of these antibiotics that can drive that resistance. There needs to be more research and development for novel vaccines, diagnostics, and antibiotics as they become resistant to the ones we use most commonly. Also taking a One Health approach, which are shown here in the top right, where addressing antibiotic use in the environment, in humans, and is in the agriculture equally to build off each other to prevent AMR. Increasing international collaboration is a huge part of this, especially as I showed that AMR burden is not the same the world around, and so there are lots of already existing global initiatives that I'm showing some examples of here to try to collaborate among different groups to at least track antimicrobial resistance, to define the problem in different parts of the world, and to build collaboration between these groups. And then finally, to do organism surveillance, to actually identify these organisms, track how they're spreading within countries, within institutions, or within healthcare facilities, or between countries. And using the genomics approach is a major way that we can do this. And so kind of step back and give a sort of an overview of how genomics is being used in AMR. In Dr. Havey's introduction, he talked a bit about what genomics is, which is to understand the genetic component, the genetic makeup of an organism, whether that's a human or a bacteria or virus or fungus, and understanding how those genes interact with each other and with the environment to produce a particular impact. And the one we're interested in is the development of resistance to antibiotics. And so the figure on the left is just showing how sort of a representation of natural selection and how that leads to the evolution and the emergence of traits within a population, which can include resistance. And so this is just showing how you can start with an organism as it divides, especially within bacteria, that mutation rate is higher than it is within an organism like a human or an animal. And so more mutations develop every time that the bacteria divides. Some of those are lethal, meaning that the mutation is not compatible with life, and so those do fall out of the population. But as it continues to evolve, sometimes a selective pressure occurs. And in the case that we're speaking of here, so the bacteria become exposed to an antibiotic. In that case, that antibiotic may select against some of those bacteria that are not resistant. They haven't developed those mutations that give them an advantage when that antibiotic is present in their medium. And those are killed off, but then that allows overgrowth of those bacteria that are resistant to that bacteria or that antibiotic. And that's shown a little bit more on that figure on that right there, where if you have a large population of bacteria, so in an infection like an pneumonia, for example, there's multiple different bacteria within that population. They continue to divide. Some of them are, at a low rate are developing mutations. Now you expose that population to an antibiotic, and maybe it's not quite the right antibiotic, or it's not a long enough course, or it's not, or it's too low a concentration, and that kills off most of the bacteria that are sensitive to that antibiotic. But that smaller population that is resistant, or has a little bit of a propensity to be resistant, that continues to expand within successive generations, and now you have an antibiotic-resistant population. And so some of the ways that we can use genomics is through whole genome sequencing. That's most of what we do within this genomics sphere, is that we take organisms and we can sequence their entire genome, so we know the entire complement of genes within that organism. And so if we do that from a single culture, from a single infection, for example, then we can take that sequence data and we can identify what are the genes within that organism and how do they relate to each other. But the real power comes when you're doing that from multiple different organisms within a particular hospital or within a particular region or around the world. And that's when you can start to take all the different genetic sequence data and you can start to put it together and start answering questions like, how are these organisms related to each other? How did they evolve from each other? And, you can start to understand what's the population size. Is it growing? Is it reducing relative to others around the world? You can start to track those organisms. If you know how they're genetically related to each other, you can see the similar organisms based on their genetics moving within within a hospital hospital, within ICU wards, or even with, between countries. And you can start to identify where are the places that are under selective pressure. So as they're being exposed to antibiotics, what are the parts that are mutating the fastest? And those are the parts that are most likely to be responding to that antibiotic pressure. So a few examples of how we here in the Institute for Global Health are trying to use genomics to fight against the spread of antimicrobial resistance. One example is an ongoing project that we have in Pakistan to actually look at antimicrobial-resistant fungal infections. And we've talked a lot about bacteria, but yeasts and other fungi are certainly an emerging and important problem in antimicrobial resistance as they become more and more resistant to antifungal infection or antifungal medications. And so one organism that is of particular interest to the global community is called Candida auris. This is an organism that is a big problem in healthcare environments because it likes to stick to surfaces. It's very hard to eradicate, and it tends to have a high level of antimicrobial resistance. And so working with our partners in Pakistan, we are collecting these antimicrobial resistant Candida auris samples from infections around the country and using genomics to characterize what the mechanisms of resistance are and how they are related to each other, how they're spreading around the country or within the hospitals that we are working with, so that we can start to develop programs to prevent their spread. We're also developing a global surveillance network through the Institute for Global Health to track AMR bacteria. The goals of this project are to collect high-quality susceptibility data from multiple countries around the world, to build local capacities within these regions to do their own whole genome sequencing and analysis, not necessarily to have to send everything to the US to start to identify those organisms that are the most important to their own communities, to be able to do the sequencing and specifically the analysis within their own hospitals, within their own labs, to start to do transmission tracking and to understand what are the genetic mechanisms of antimicrobial resistance within their particular populations of interest. And then starting to build up enough data to start to use AI and other tools to improve diagnosis and treatment of AMR infections. And we'll talk about that a little bit more in a couple more slides. So like I said, doing the actual sequencing and analysis is one of the big goals that we have within the IGH to try to build capacity for that. And towards that, we have been developing these genomics and AMR workshops that we have delivered at multiple partners around the world. These start with a development of a curriculum that is both generalized but also specific to the organisms and the capacities of our partners. Often we will travel to those sites and develop and deliver an actual workshop. And I'm showing here a few examples of some that we've done with our partners in Pakistan, as well as in Freetown, Sierra Leone, as well, and in Lima, Peru, where we actually did both an analysis workshop, but also a whole genome laboratory sequencing workshop as well. Then as part of this, we build a global scientific community, as well as a global healthcare community that is focused on doing genomic surveillance of antimicrobial resistant organisms and start to develop this independent as well as interconnected analysis skill set that we can all contribute to and also all benefit from as a, both locally and as a global community. And so, like I said, I want to talk a little bit more about artificial intelligence and how that is being applied to antimicrobial resistance. Artificial intelligence is not just used for making funny videos, but it actually has some real world sort of both research and healthcare applications. So really just kind of give an overview of what I'm talking about when I say artificial intelligence. So artificial intelligence is kind of as a term is sort of a broadly encompassing term, and really just indicates that these are ways of teaching computers to think and make decisions on their own without human input. A subset of artificial intelligence is a discipline called machine learning. And so machine learning is specifically to an application of algorithms, of artificial intelligence algorithms, to learn from data, to be able to analyze that data and start to make predictions or decisions based on the data that is being processed by the computers, by the artificial intelligence algorithms. And then even as a subset of that is something called deep learning. And that is a way of using machine learning in a way that mimics the way brains actually think. So using sort of these artificial neural networks that are structured the way our own brains think to really start to identify features and connections in data. And so where this comes in, very useful is when you have a large amount of otherwise disparate data, things that would otherwise be difficult to kind of connect to each other. And these deep learning algorithms can start to take those kinds of data and start to identify the connections between them and make predictions based on those. So the kind of data that I'm talking about can include things like demographic data. So this is including, ages of individuals, where they live, other sort of demographic characteristics of those individuals that are developing AMR infections or not. Clinical data such as what kinds of infections they have, what the outcomes of those infections are, what they've been treated with. Then we can use microbiologic data. So what are the organisms that they're infected with? What are the characteristics of those organisms? When we test them in a lab, what is their resistance or sensitivity to different antibiotics? We can use genomics data, like I just talked about, so actually sequencing those organisms and identifying the genes and the genetic structure of those organisms. And environmental data, what are the temperatures, what are the water levels, what are the exposure to animals within that community. So it can take all these different data sets, and these can all go into these AI models together. And some of the applications, how we can certainly, process this data and the questions we can start to ask. One would be, to start to improve our diagnosis of AMR infection. So being able to identify them earlier based on characteristics of the patient or the organism without having to go through sort of the more prolonged laboratory approaches that we're currently doing. And also to be more accurate in terms of predicting whether an organism is resistant or sensitive. Second, we can use this to improve our treatment of AMR infection. So are antibiotics even needed? Like Dr. Hawkins said, a lot of infections don't necessarily need an antibiotic. If it's a viral infection, which isn't necessarily always easy to diagnose. Sometimes the combination of all these data will be able to more accurately identify whether somebody even needs an antibiotic in the first place. And if they do, which antibiotic is going to be the most effective for the kind of infections and the kind of organisms and where they live and things like that. And then finally, this data can be used to start to jumpstart the development of new therapeutics. So this can be the development of new antibiotics based on the genetic structure of these organisms, or even just inhibiting the resistance that they have, so we can continue to use the antibiotics that we have currently, but to block the resistance mechanisms that they currently have against those antibiotics without having to develop new ones, or start to better understand how different combinations of antibiotics or other medications together might boost the effect of those medications to treat AMR. And so the ongoing challenges and limitations for these approaches is they do require a lot of data, and that data has to be good. It's sort of this garbage in, garbage out idea, is that if you put in not so great data into these models, then you're going to get not so great models in return. And so, and the data quality is quite variable depending on where you are and what your resources are. And so that's one of the things that we're hoping to improve with these global programs, is starting to improve the quality and using a more universal data set from around the world. And also just these, models may not necessarily be generalizable, again, depending on what kind of data you put in. So if we build models, if we go where the light is, meaning that we have a lot of all this information from North America or Europe or other high-income countries, and if we take all that data and we build models from that, are those models actually going to apply to other places where we haven't looked very well, within low and middle income countries? And so these are the roadblocks that we're hoping to overcome, and are going to be very important, not just within IGH, but within the entire scientific community that is studying AMR. Okay, so just to summarize what Dr. Hawkins and I have talked about today, just to kind of sum it up in just a few bullet points here. Antimicrobial medicines save lives by treating infections. This is, I think we've shown that quite effectively, but resistance to antimicrobials, so AMR, occurs when the germs survive the drugs that are designed to kill them. The drivers of AMR, as we've shown, are inappropriate. The large ones that contribute the most are inappropriate treatment, both in humans and in animals. Poor sanitation, leading to increasing spread and increasing exposure to infections with AMR organisms, as well as, unfortunately, an aging population with greater amounts of comorbidities, such that they're more likely to get infections. And when they do get infections, those are more likely to be AMR type. The development of new antimicrobials to treat AMR infections has been slow, and as you saw from Dr. Hawkins' slides, they've actually relatively stalled out in the last several years. There's been less and less development of new antimicrobial medications, and there's a lot of technical and other reasons that is the case. AMR infections occur in all regions of the world, but the burden and the causes are not necessarily all the same. And we don't know what we don't know. If we don't look, we don't necessarily know what is going on in different parts of the world. And finally, the collaborations around the world to provide capacity building and technologies are needed to address these AMR challenges on a global scale. And with that, I'd like to thank you all for your attention and send it back to Dr. Havey.
Thanks so much, Egon, Claudia. That was amazing. And I understand for the audience, this is pretty technical, but think about it in perspective. In fact, I've got a number of questions that folks who signed up for the webinar sent in advance. And in no particular order, I kind of looked through them. And I thought the first one to kind of talk about is a question that came from the audience. And I'm going to give a quick comment and then have Egon and Claudia weigh in. But someone sent a question that said that, are we now at a point where we're seriously concerned that any of us could acquire resistant strains of bacterial infections just in our usual community? Keep two things in mind. First, most people know what MRSA is, or MRSA, MRSA used to be rare, and then it used to be something that it only happened to somebody who had been in a hospital. Today, more than 50% of staff in the community, just out in the neighborhoods, is resistant staff, more than half. So as doctors, when we have a patient come in with a soft tissue infection, an infected leg or a wound, we assume it's MRSA till proven otherwise. So this stuff is not theoretical. This is happening right now. Secondly, the second point about that is that before we went live on this webinar, Dr. Hawkins was joining, and she's been on service right now. And keep in mind, all of us, when we turn these cameras off, are back taking care of patients, which is, the difficulty of our work of handling local care, global health, future trends. I mean, it is an amazing amount of dedication by the folks in this institute. That they put in all this time, night and day, 7 days a week, and they do it for the purpose. They don't do it for profit. They do it because they want to advance the science and help humanity. But Dr. Hawkins mentioned that she had 20 new consults just today, people in the hospital sick with infections that the local teams can't handle and need infectious disease to weigh in on, and that all of them were resistant organisms, all of them. So what does that tell you? So I'll turn this over to Claudia and Egon. Can you comment on, are we at a point where everybody should be a little bit concerned about picking up one of these infections?
Yeah, I can start answering that question. That's a great question. And as you said, Dr. Havey, MRSA is one of the more prominent examples. And yes, that used to be, even within my lifetime, that used to be a fairly rare infection. 10, 15 years ago, it was pretty rare that a Staph aureus would be resistant to methicillin or other penicillins like that. But that is definitely more common now. And like you said, we just assume off the bat that if there's a staph infection, that is MRSA until it's proven otherwise. But it's not just staph, but in general, yes, there is an increasing burden of antimicrobial resistant infections coming from the community. There have been studies that have been a few studies that have looked at infections in hospitalized, individuals that they thought they got their infection from being in a hospital versus those that came in from the community, didn't have a prior healthcare exposure, and looked at the rates of resistance between those. And there's been some studies out of Italy that have actually looked and shown there have been about equivalent, the amount of infections both in the hospital and from outside the hospital that were resistant to antibiotics of one kind or another. And at this point, about at least half of community-acquired pneumonia. So this is, again, people that develop a pneumonia in the community that have never not had significant healthcare exposures. About half of those are resistant to at least one antibiotic that we would normally use to treat a pneumonia. And so there have been other groups that have gone to look and see whether they can actually find these antimicrobial resistant organisms just out in the community. You're not just looking at causing infections, but do they see them in places where people might become exposed to them, and they do when they've done studies to look at sort of high touch areas in the built environment. And what I mean by the built environment is buildings and houses and public spaces, and when they've looked at places where there have been high touch areas, and they've looked specifically at on public transport and buses and trains, as well as sports arenas or in schools on door handles or desks and such. And in every one of those situations, they are able to find at least a subset of those organisms are antimicrobial resistant. And we do believe that at least some of those infections do come from those places. And so some of the reasons why, as Dr. Havey said, there's been more and more an increase in the amount of resistance that we're seeing out in the community is potentially because we're starting to see more of it in the wastewater, starting to get into the environment. As I mentioned, we have some examples of that, as well as in our livestock and produce, the things that we encounter in grocery stores and such. And so there's just becoming an increasing risk, of colonization of our own microbiomes, which is fine, that there could be AMR bacteria there. It's not until an infection occurs, and then if it's already part of your skin or your gut, that there's just a higher likelihood that infection is then going to be caused by an AMR organism. And so,
Great. I'm
it is
gonna
important.
move.
Yeah.
Great. Thanks, Egon. I'm gonna move question number 2, because you just answered that so comprehensively. Claudia has nothing left to say. So I'm gonna direct the next question to Claudia herself.
Yeah.
And that was a question for the audience that said, if we don't do anything different, if we continue our current trajectory of what we're doing, managing resistance the way we currently do it, what do you see the future holding for us, Claudia?
Yeah, I mean, a great question. And I think I tried to answer some of that with the sort of projections from the Lancet article, where they're predicting sort of millions more deaths with antimicrobial resistance by 2050. And those projections are quite stark and quite concerning. Yeah, I mean, if we don't do something about it, we will just continue to see that explosion of antimicrobial resistance. And as I mentioned, there are many, drivers around this. We're going to see this only increase just because of the population at risk is going to increase, the globalization, the interconnectedness, would argue that some of the cuts we see to some of the healthcare services, as well as some of the sort of surveillance programs, may also play a role in that. But yeah, I mean, I think we have to kind of look at it as back to the pre-antibiotic era sometimes. I mean, I get terribly frightened when I see, like I did today, something that is completely resistant to everything, even the newer antibiotics. And if that isn't a warning for the future, then then I don't know what is. So we have to really look back, I think, to look forward and remember, go back to our history and look at sort of years ago, we were dealing with, huge fatalities from meningitis and endocarditis and the things that we just didn't have good antibiotics for. And there's no reason that, if we continue on this trajectory and we don't develop new antibiotics or new therapeutics or really address some of the prevention of this, then we could end up back in that situation. So sorry to be so dire, but I think that's the worst case scenario. So.
The interesting thing is, we all, as physicians, go through a number of lessons we learn over the years, and maybe I'm the oldest one on this line, even though I know I look like the youngest, and that's okay. But there was a quote in the mid-70s, that's just 50 years ago, where a prominent Harvard infectious disease physician, and all ID docs remember this quote, said that we have done so well with antibiotics by the mid-70s, we no longer need infectious disease specialists. In fact, that particular prominent physician counseled all docs in training not to even go into infectious disease. Don't bother, we've got it licked, it's gone. That's 50 years ago, and look what's happened. Pandemics, resistance, HIV, resistant TB. I mean, and this was a specialist in the field who really thought that that person could read the future, that our technology had solved this problem, and we're in more trouble than ever before. So the next question that came up is, what do you see, since we know there's a problem, we know that if we don't do something, we're all in trouble. What's getting in the way? What are the roadblocks that you see getting in the way? So Dr. Ozer, you get 1 minute on this, and Dr. Hawkins, you get 1 minute, so that the audience can hear from both of you.
Yeah, I would just say, some of the bigger ones that I see is, I'm a clinician, but I'm also, a researcher, and I have been seeing, as Dr. Hawkins mentioned, this sort of the slowdown in research most recently has been quite obvious, and is a huge problem. But this is, the research has been slowing down for quite a period of time, even before even before 2025. So there's been kind of less investment in antimicrobial resistant research that's been ongoing for at least several decades. And as recently as last year, it was 2024, early 2024, there was an industry body that was of pharmaceutical companies that was already complaining about the brain drain in pharmaceutical research for antimicrobial resistance, because there's sort of low investment by pharmaceutical companies, low investment by government entities, even leading up to this time in antimicrobial resistance. And there, I guess I sort of mentioned some of that is economic, and it's just this sort of slow-moving pandemic of antimicrobial resistance that is sneaking up on us, but is becoming more and more of a problem. So I do think that's one of the biggest roadblocks is lack of research and support for research in AMR.
Claudia?
I'm most worried about some of the resource poor settings. I mean, I think I said in my slides we are facing a tremendous problem with antimicrobial resistance in these areas, and particularly more so now, I think, with some of the funding cuts, but also sort of aging populations in these countries, the real strains on the healthcare systems just in general, that they don't have the adequate surveillance systems, prevention and control programs. We still got sort of minimal antibiotics, but in that context, in some of those areas, but in that context, overuse of these antibiotics, just sort of inappropriate prescribing, and sort of, along with that, sort of educational issues. But I really do worry about what we're going to see sort of really in those countries. And I think without the surveillance, without research, without investment into the research programs, particularly focusing on the prevention side, I think we're going to lose pretty quickly. So.
Thank you. The next question, I'll turn this to you first, Claudia. You've had incredible experience at the main countries in Africa where you've been involved, and you've spent a lot of time over there. You know the communities, the cultures. So someone sent in a question that said that there are so many cultures and languages and different affinities in Africa. How do you address all these people? How do you address the differences? How do you involve those communities to help you develop solutions to these problems?
Yeah, I think that's a great question. And I've worked in many different countries, primarily in sub-Saharan Africa, but also elsewhere. But and obviously interacted with many different cultures, a few languages, but so yeah, I mean, the important thing is to engage the community, and that was exactly what the person is asking about. And how do we do that? I mean, really, you do that from whatever you're going in to do, whether that's a clinical service project or whether you're going in to do some research. or even, just advise on clinical or something, you really do need to engage the community in a way that's really the way that your solutions you're proposing or talking about all together is going to work, and everything that you're contributing to is sustainable. With our research, I mean, I have more involvement with research programs and research training programs. The research is done by, I just try to make sure that that research is done by the community. So it's done by our collaborators. It's not me going in and doing the research. It's not just going in there, coming out with our research findings, and there you go. And so I love training programs for that reason and leading those, because they are all about building capacity for research for our researchers on the ground, so our local physicians, etc., to do that research themselves. We engage the sort of lay community in all those projects. You have to do it from the beginning, when you're even thinking about the design of the study. It's important to engage people along the way. We don't do a good job of it. I wish I could do a better job of it, but that's really what makes for a most successful project. Because when you're engaging the lay in the community, you're understanding the local context, and it means so much for a successful research project. I mean, me personally, when I've traveled there, I try to also not just be a sort of in-out. I do try to kind of learn as much. I've had a great period of time living in Tanzania, where I learned a lot about the culture. I tried to learn the Swahili. I wouldn't say I was a very successful, but I think things just like living locally and reading. I always read the newspaper when I'm there. I need to know what's going on the ground. I talk to people. We don't, like I say, we're not there just fleeting in and out. And as a mentor now to many trainees on the ground in Tanzania and other African countries, I really, we are in such a privileged position, having access to a lot of different networks, a lot of different people across the world. So as much as I can, I help build those local and global networks for my trainees who don't have that access necessarily. So as well as doing the mentoring. So I'll stop there.
Egon, I'm going to give you the last question, but before I do, since we've got only a few minutes left, I want to remind the audience that we do have our annual fundraiser and really showcase event where we have you meet a number of the people involved in our global health work. We show a lot of nice student speakers. You get to listen to me if you want to take a nap. And then we show a really nice video, and that's on Wednesday, September 17th, just down the street in the Peninsula Hotel. You can go online and look for our invitation. We'd love you to come and participate and really enjoy meeting us and other people who've supported the Institute. But that leads to questions about philanthropy and gifting and so forth. I'll be announcing that night an amazing $1 million gift that the patient has given to the Institute. I won't say the name yet because we're going to make that announcement that evening of who gave that gift and who it's in honor of. But that gift is being used for this topic. It's being used to create a network of partner sites around the world to study the genomic reasons for antimicrobial resistance around the world, as a great step to kind of tap into the science of why are all these organisms, viruses, bacteria, fungi, becoming resistant to everything we have to hit them. If we don't figure out why, we're not going to find a solution. So in the 2 minutes we have left, I'll let Dr. Ozer mention, since he's excited about this project, and he'll be equipping these countries around the world with gene sequencers and showing them how to do this technology and how to raise this data. And then really we're building basically a compendium of data, a library of the bacteria, fungi, and viruses around the world that are becoming resistant, and what their genomic structure is, so that we've got a really strong base. So it's going to be a great use of $1 million gift. I mean, the one thing the Institute's proven is we get a lot of bang for the buck out of what we do. All of us on this line do this as a contribution. I'm in my 20th year with no compensation, just doing this for the good of the project and for the good of the world. And we love your support on this. So I'll close by letting Egon tell us a little bit about what we're going to do with this wonderful new gift.
Yeah, thank you so much, Dr. Havey. So, yeah, this philanthropic support is a huge source of funding, and a really important one as well. Some of these projects are very difficult to get funded in any other capacity, because they are very diverse. They're very they aren't necessarily NIH or other funding organizations like to fund in terms of sort of small or very directed projects. These are kind of larger, more complex, and so these really do depend a lot on philanthropic funding. But what they do is they allow us to start to develop these projects and these connections to build the frameworks to establish, cement the connections that we have with these partners around the world that then can lead to stronger collaborations to develop, to get projects rolling and start to develop, produce data and to start to produce results that can then be used to receive other funding and other support for these projects. And so, as Dr. Havey said, we are embarking on a very exciting project to start to work in several countries around the world to build up their capacity for genomic surveillance of AMR organisms, to start to develop local banks of organisms that they can use to study locally, and as well as to contribute to this global effort to understand what are the mechanisms of resistance and how are they spread within communities and around the world in ways that I think other projects are not doing to this level. So we're really excited for that philanthropic support to get this off the ground.
Perfect. Well, thanks so much, Claudia, Egon. Thank you for that. Thanks to the audience for taking time to tune in and hear about our work. And thanks always for all your incredible support. I'll let Jen Burke, who, along with the rest of our team at the Feinberg School of Medicine, have been wonderful supporters of our work and help hold this all together. I'll let her give a little closing comment.
Sure. Thank you so much, Dr. Hawkins and Dr. Ozer and Dr. Havey, for speaking with us today. If any of our attendees are interested in learning more about the Havey Institute for Global Health or supporting our work, you can visit us at globalhealth.northwestern.edu. We will be sharing a recording of this afternoon's event by email either tomorrow or on Friday, so you can take a look out for that. Again, thank you so much for joining us, and we look forward to seeing you again soon.